Good morning. Given that this room is completely full, we'll get started about 5 minutes earlier, which I hope is okay for you guys. We've got a lot of content to cover. So I'm Andy Day. I'm the Global Industry Director for Healthcare and Life Sciences at Tableau. What that means is I run the strategy, go-to-market, partner ecosystem, and biz dev for provider, payer, pharma, and med devices. I orchestrate and host the Healthcare and Life Sciences track, so it's a matter of intense pride for me to invite you to the kickoff session of the Healthcare and Life Sciences track at 2016. So I have the dubious distinction of earning my 3 master's degrees in business and engineering from 3 countries. But I'm humbled, I'm completely humbled relative to our next speaker, who's a medical doctor, so trained to talk about physiology, anatomy, and internal medicine, has a master's in public health, so she can talk about epidemiology, and also has an MBA, so she can seamlessly move into EBITDA and ROI, right? So one of those rare breed. So it's my honor to introduce Dr. Divya Malhotra, who's the Director of Analytics and Innovation at Stamford Health. And what she has for you is a treasure trove of use cases across clinical, financial, and operational processes, which I think you'll find extremely valuable. So ladies and gentlemen, Dr. Divya Malhotra.
Thank you. Thanks. Can everyone hear me? Okay. Thank you, Andy, for the introduction. Just for the record, I graduated from business school when I was 5, so I'm not that old. I know, because these introductions make me sound old. I don't want to feel old. All right, so today we have a packed agenda, and my goal for you today, and I realize that you guys have a lot of options for sessions to choose from, and you chose this session, so I want to make it really productive and fruitful for you. And my goal today would be to give you some actionable and insightful use cases and something that you guys can take back to your organizations and improve healthcare, improve patient care, and improve the way you guys do business using analytics. And tell you a little bit about our journey and some of the lessons we learned along the way. So I'm not going to bore you with the agenda, but I want to give you a little bit background on our organization just so you understand the context of the entire journey. We are a single hospital system. That's our new building that went live September of 2016, and we're just one hospital, 305 beds, about 15,000 inpatient visits, and 400,000 outpatient visits. And we do employ some physicians, but we also have an active medical staff that's community-based. We're in a very competitive environment. That gray dotted line is the New York State border. So we're a train ride away from New York City. We're really close to Yale, and we're surrounded by hospitals. So there's a hospital every 3 exits on I-95 as you go from New York to Connecticut, for those of you who are not familiar with that area. So you can see that we're in an intensely competitive environment, and that made it really, really important for us to improve our analytics and to have performance driven by good data and good analytics. So how do we start our journey? If you walked into our hospital or our system in 2010, 2011, and you asked for data, you got something like this, right? You would call finance, they would tell you, oh, go to IT, I think you should put in a ticket there. And then IT would tell you, no, I think maybe the medical group has that data because you want some physician practice data. So you would just be lost in the conundrum, and it was really discombobulated and really, really broken. So what happens when a system is broken like that, right? When there's too many things going on? You have a question that you need answered. You don't want a product, you don't want a software, so you're not going to give it to the IT pipeline because it's not a piece of software. It's a decision you need to make for which you need data. So you put in the ticket, for whichever department it is, you wait there, and the report factory then churns out the report, right? It might be 2 days, it might be 4 days, it might be 4 weeks, it might be 6 months, right? Depending on where you are in the queue. What happens in that situation? Your question is not answered, so you never know what it could have been because the question wasn't answered. You lose the opportunity that's there, and you may not ever get it back. So there's a huge cost to actually having a disjointed system like that. So obviously the first bullet is very easy. Everybody knows there's waste and duplication if something like that exists. But the other 2 are kind of interesting. It might be happening in your organizations or may have happened in the past. One is answer shopping. a lot of people, what they do when they need something, they call finance, they call IT, they call the process improvement group, they call everybody, because somebody will get it to them in time. And that's answer shopping, and a lot of organizations do that. And it's really bad culturally, because if ever those two groups talk to each other and they find out that you're asking them for the same report, it's not good. And it just sets a very bad cultural precedence for analytics in the organization. And then collection fatigue. I was talking to a nursing quality analyst one time, and she said, Divya, you know, it takes me about 15 days to put together this report, because I grab it from Excel, I download whatever application, I do this, I do that, I put it in a CSV, then I create a graph. I don't even have time to look at the data and see what it's telling me, right? Because I'm totally tired by the time I put it together, because I know I have to do it again in the next 15 days, right? Because it's a monthly report. So that happens to a lot of us, and it's a lot of, again, it's a cultural problem, and it's also a cost and employee satisfaction issue. So this was our platform sort of environment before we went on this journey with Tableau. We had mostly application-based reporting. All of our EMRs and HIT systems were all had their own reporting modules. We would pull them down into Excel, very standard environment. And then we had a lot of third-party products where we would give them data feeds and they would spit it back to us in charts and graphs and those gas gauge things. And IT tickets, right? Those are standard things as well. And I'm sure it resonates with a lot of you, because a lot of organizations have that. How did we transform? So in about 2012, our executive councils decided that they needed to fix this. There was an issue, and it was sort of going back up into the CEO's office, right? Because he wasn't getting what he needed. Data was always a problem. People were complaining. So we created this business intelligence function, and I was tasked to lead it. And we worked really closely with the IS department and IT to set up the right infrastructure, to set up the right data warehouse, and I'll go into that in a minute, and have a steering council that directs and guides our initiative. And then obviously, the ultimate goal is to serve the end users. These are our objectives, and pretty standard, right, with anybody going down this path and making analytics better. We wanted to reduce silos in terms of silo analytics that existed within platforms. We wanted to make data a strategic asset, and we wanted to leverage data to power improvements, right? Data in itself doesn't do anything. I could have 15 scorecards running daily, weekly, monthly, but unless somebody is looking at them and making improvements off of them, and actually doing something to drive business or to drive better patient care, it's useless. So those are the technical sort of, what are our objectives with this department. But here's what I wanted to show you, right? We were spending a lot of time collecting data, very little time analyzing, and very, very little time improving. And what we wanted to do is not spend time in that collection phase. You want to improve, you want to make changes, you want to drive your business, drive better patient care, and that was my personal objective as I set out on this journey. And what happens, this is sort of like the evolution from a theoretical, like conceptual process, right? You want to establish a good data warehouse first. So that's the first step. So you're starting to first leverage the infrastructure, leverage all your applications into a good data warehouse. Then you develop the analytical competencies, which we use Tableau to develop. And then finally, once you have everything ready to go, then you optimize your processes, because you're looking at the data, it's churning out pretty quickly, it's visually appealing, leaders can make decisions, clinicians can make decisions, and overall the organization is in a better place, right? So how do we work with IT to do this? So one thing I want to say before I dive into the actual infrastructure and then into the use cases. Every organization is different, but for us, we had a huge constraint on costs. They had already set up a department, we had hired some staff, they did not want to spend $2 million to build a big infrastructure. So we had very little capital to invest, and we wanted flexibility, and we wanted something fast. And Tableau was the only thing that was fitting into that structure. And the last thing, which was very important to us, we had a SQL Server backend for some of our big databases, so we wanted to keep that SQL Server infrastructure for our data warehouse. So we did that. And the approach we took is we identified certain users, certain early adopters, and really drove some of the projects. And you're going to see some of the stuff that we have as use cases soon. But we use these big ticket items, big ticket projects to really create a buzz with Tableau. And then deployed it across the organization. And now at this point, it's just cool to have Tableau dashboards in our organization, even if you don't know what you're looking at, but it's cool to have Tableau. So that's sort of the cultural sort of shift that has happened. So this is the IT landscape, just so you understand. We have multiple applications, just like any other hospital or healthcare organization. We have Meditech on our hospital IT side. We have eClinicalWorks or ECW on our physician practice, ambulatory side. We have ADP for our employee data. We also have Kronos, which is not listed here. Press Ganey for patient satisfaction, and Connecticut Hospital Association, which is our market share and hospital sort of blinded data for other hospitals. And then on top of that is our SQL Server environment, which is our data warehouse. And then on top of that is reporting, which some of the simple reports like line lists. So let's say if our EP doc calls me and says, hey, I just want a list of all the patients with atrial fibrillation that come into the ED. It's a simple report, it's just a list. So sometimes we just crank it out in SSRS, and IT and data warehouse team takes care of it and send it out to them. So we don't worry about that. But most of the visualization and the dashboarding and scorecarding is done through Tableau. So how did we build our data warehouse? So the way we kind of consolidated all this information is we had to organize it somehow, right? So what we did was we first created the patient structure, which is right there. This was everything that happens to a patient in the hospital. All encounter level detail, all billing data, all demographics, diagnosis codes, procedure codes, lab, medication, everything is housed in the patient structure. So our data mart for patient information is stored there. All of our financial information, which is general ledger, accounts payable, invoices, those kinds of materials management, that kind of stuff is all sitting in the financial structure. And then we have employee structure, which just went live recently, a couple of months ago, which is all of our ADP staffing data feeds to do most of our nursing staffing analysis, et cetera. And then external data sources like CHA data, which is Connecticut Hospital Association, and Press Ganey, and all those things. And then last but not the least is the manual data sources and web forms, right? Anybody who's from a hospital or healthcare organization knows that there's a lot of quality reporting going on, which is manual. And it can never be fully automated. And if anybody says that it can, they're lying to you. It can never be fully automated, because hand washing, that's not gonna come from, you don't wanna create a separate software for that, because it's just, observations, right? So what we have done is we've created these web forms where instead of entering it into Excel spreadsheets or paper and then emailing those hand hygiene rates, they're submitting that monthly data into a web form, which is then getting sucked up by our data mart and then getting published into Tableau as a view, and then we're pulling it together that way. And I'll go into detail with a use case with that as well. Before I jump into use cases, a couple of things. I know self-service is a buzzword, but I think self-service can be overrated, because a lot of people are not quantitative in nature. You guys are, because you're sitting here, but a lot of people in the organization are not. And you don't want to give them too much data, too many filters. There's like a narrow window of flexibility that you want to allow. So they should have some flexibility, but not too much, because then they get lost, they pull wrong data, they make wrong decisions, and it all comes back to you. The key thing is fast turnaround, because people are just frustrated with the slow system and the bureaucracy inherently that's built in. You want to just break that down. For instance, if somebody had asked us, what is the contribution margin for outpatient breast surgery cases in 2010? It would probably take us anywhere from 8 weeks to 10 weeks to give you the answer. today, with the infrastructure that we have, it probably takes us 10 to 15 minutes. So that's what you want. And self-service is not really, what they mean by self-service is I want my answers fast. So diving into the use cases, I just want to say you'll see a lot of use cases here. And I want to explain some of them to you. Some of them are really tiny, so please bear with me. But I think it's very valuable information, and I wanted to share it with you so you guys can use it in your organizations and hopefully improve your processes as well. But this is teamwork. My entire team has worked on it. This is not me personally. So a lot of credit goes to having the right staff and the right team to build all this stuff. So clinical and quality. So let me first jump in. I'll do clinical, I'll do operational, throughput and efficiency, and financial finally. So the first project, one of the earliest projects that we did was we looked at our clinical resource management opportunity. So our executive team was wanting to look at reducing clinical variability in the organization. This is a problem a lot of organizations face, and I'm sure you guys are all working on it in some way, shape, or form. And it's like boiling the ocean. It's a huge project. So how do you tackle it? So you either do bottom up or you do top down. We decided to do top down, and we quickly looked at our DRGs and to understand the overall potential savings and potential opportunity with our top DRGs, which are the most variable. And this is sort of a graph, and I'm going to dive into it a little bit in the next slide, but our total opportunity that we identified was about 5 million. So you can see our biggest sort of outliers were rehab, C-section, psych, sepsis, heart failure, and ID. ID was also, we found later, was part of sepsis. Some of the sepsis patients were being coded as ID service. So you can see that sepsis and psych and C-section were huge. So how did we get to it? So the first thing we did was we just looked at DRGs overall. We looked at volume and we looked at cost. Sorry, I'll go to the cost later. We looked at volume and we looked at length of stay. So you can see here the length of stay is stacked up here, the volume is here, because you don't want to go down the path of just looking at length of stay, because if your N is really small and volumes are really small, that the impact is not that great. So you want to always sort of measure it up with the volume as well. So what you can see here is this is the length of stay, and this little square here is this Medicare benchmark. So we compared all of our data. So we used our patient structure and counter level data to build this, and we compared it with the GMLOS for CMS, and then came up with avoidable days using 1 year's worth of patient days. So you can see some of them sort of stand out because the volume's not in that much. So you may not want to pursue them because you want to identify and work on the most identified opportunity. So we looked at, so for instance, 885, which is psychosis, is a good example. It is very high volume. It is high length of stay. Look at how far ahead it is of the Medicare benchmark, and there's about 1,500 avoidable days just for psychosis alone. That's a huge opportunity, right? So you know it's immediately a red flag, and nobody really knew it. And we found out later that we needed an overall behavioral health overhaul, and we're going down the path with this. So that was the avoidable day and the length of stay piece, right? But then what does that actually mean in terms of dollars and cents? So CFOs always they just find length of stay reduction is not an actual saving. They want the actual saving associated with it. So we do this cost analysis associated to the same analysis that you saw in the previous slide. So what we did here was we took the variable cost per day for those DRGs that we identified, and we multiplied it by the avoidable days that you saw there, and we got the opportunity dollars. So this really gives you how much extra are you spending on these patients. So for instance, let's just follow psychosis through. So it's about $700 a day in variable cost, but because there's so many avoidable days, that 1,500 or so, so that's why it added up to $1 million in variable costs. And then obviously you want to do a contribution margin and a return on cost. So this is an interesting metric because, and we were able to do it really quickly with Tableau. If we had to do it in Excel, it would probably take us more time. But what we did was we divided the total cost. We took the total cost and divided it by the actual revenue that we got on these cases and came up with how much do we make on every dollar we spend, right? So you can see some of them, if it's over one, you're making more than you're spending. But if it's less than one, you're actually losing money on the case. So this also helps us to identify. So for instance, 885, which is psychosis again, we're only making 49 cents to a dollar. So it's not, obviously, absolutely, we identified that that's an area we wanted to work on. Overall, we identified a few clinical projects that we had to work on. Heart failure was one. C-section we identified, but there were payer-specific issues because they were paying per diem, so we had to bank that separately. And then sepsis was the other one that we had identified with a lot of saving potential. So what did we do? So we looked at length of stay. One of the things as our team got together and put together a Lean Six Sigma project around length of stay, we found that a big correlation, as they did the root cause analysis, we found that a big correlation was giving the IV Lasix earlier during the stay versus later. So we mapped that data out. We did the study. And I apologize, the circle moved down. I don't know how, but this is the correlation you see. If the IV Lasix is given 5 to 6 hours or beyond, your length of stay is 6.93. So it's a completely clear correlation that you see here. So what ended up happening is that our CHF committee ended up determining a new clinical pathway. You can see the screenshot of the pathway in the ED. So they would actually administer the IV Lasix up front in the ED as opposed to waiting till the patient gets on the floor. And it really did help our overall length of stay. And we continue to monitor it using this. Sepsis, another one of those areas where better patient care would lead to length of stay. So we created a sepsis committee, worked on improving sepsis care and reducing length of stay there. And one of the things we did there as part of the overall project was to meet our follow-up ringer lactate goal of 6 hours. So we wanted to meet the goal, so that dotted black line that you see up there, that's the ringer lactate 6-hour goal. And you can see that our overall trend went down in 16. And we're measuring it. We continue to monitor it currently. Okay, so this is another one of those really neat examples where I think we did it using Tableau in about 3 to 4 days, and this was actually used to drive physician performance. So bear with me. I know there's a lot of stuff here, but what happened was, to give you the backstory, our surgical chair came up to us and said, I realize that some surgeons are using a lot more resources and supplies than others, but I have no way to prove it. I just know that these guys are taking longer, they're buying all kinds of expensive supplies. So I said, okay, let's just focus on a few procedures because we want to not, again, boil the ocean, right? So he gave me 2 or 3 simple procedures, the bread and butter stuff. He gave me appendectomy, and he gave me hernia repair as the pilot project. So this data shows appendectomy. You can see here in the top, this is for appendectomy. What we did was we took all of our surgeons and we mapped their average variable cost per case using our cost accounting data in our patient structure, and we created this sort of grid to see which ones are the biggest outliers. Then just the average variable cost doesn't help, right? Because you always want to be able to hone down, because variable cost could mean anything. We wanted to look at med-surg supply costs. So what we did was we went into the actual specific charge level data, grabbed their supply cost from our supply system, and came up with this med-surg supply cost. So this was really neat because we mapped our financial structure with our patient structure. We literally took the supply items, used it on the patients, bumped it up into the cost per unit there, and actually created a supply cost per case. Whenever you share average supply cost data with physicians, remember their first defense would be, I'm doing way too many cases. That one is only doing 2 cases a month. That's why you always need to have volume. Always have volume when you present supply cost case. And I'll show you specifically, I'll compare two surgeons. But don't forget, when you're doing the variation on supply costs, you have to have the operative times, which is basically cut to close time for your physician. So you want to be able to map both things. And you want to have it in the same view because you know where this is going, right? Because the surgeon's going to say, no, they take too much time. I do it faster and I'm better, all that stuff. So you need to have, and for your own purposes as well, you want to understand efficiency and cost together. You don't want to look at it in silos. So taking that same view, and I've just highlighted only two surgeons to compare and give you exactly where the value of this is. And we actually use this, and we did talk to Surgeon 4, by the way. Our surgical chair did go and talk to Surgeon 4 and showed him the blinded data. So here's Surgeon 4, his average variable cost, higher than the average for the group. Surgeon 6, lower significantly, so the difference is about $300 a case. Med-surg supply costs, huge, right? Because it's $1,400 versus $1,000 or $1,100. Volume, almost the same. There's not that much of a difference. He's doing 35, she was doing 29. It's not that much of a difference. And look at the operative time. She's way faster than them, right? So that's all good, right? But what happens? He's going to say, prove to me what supplies I'm using. I don't know. I don't trust your system. So the next step was, and I talked to the surgical chair, and he said, we need to have supply level items, details. We can't just go and talk high level, right? Because it's not going to go anywhere. So we came up with this report. Again, it's not really pretty, but it really works very well. Because what it did is we grouped everything that was booked or charged on the case, and divided them up with the help of our surgery nursing leader and our department chair. We divided them up into sort of logical categories. So endomechanicals were one. And you see here, this endomechanical product that Surgeon 4 was using, he used 56 of these, and she used 3 of those, right? And look at the cost there. It's $187 supply. And why was he using it? Because he was using it. There was no real reason. And for all you know, he may not have known. I'm not blaming the surgeon. Sometimes surgeons don't know how much that costs, and if there is a better replacement, a clinically better or efficacious or cheaper alternative there. So the surgical chair did go back and talk to him. And just so you know, if you multiply these two, it's about $10,000. So that's a lot of money. I mean, it's something that you would have never caught otherwise, right? But that level of detail is very important, and we were able to do it using Tableau. So that was more on the surgical clinical variation. This one is what I was talking about, manual data forms, manual data sources, and how we have sort of automated manual data forms. This is our enterprise quality scorecard that is about to go live, but I want to share with you because it's really, really cool. There were about 200 key measures that were reported in our safety and quality scorecard, just like any other hospital, right? You have those standard domains. You have efficiency, you have care coordination, you have hospital-acquired conditions, the standard ones that we always collect and disseminate across the organizations, and sometimes use it for public reporting, and sometimes have it for pay-for-performance reporting as well, right? So there was a lot of administrative burden because all these different data sources and different stakeholders were collecting this information, publishing it, sometimes sending it in emails like, oh, here's the core measure this year or this month, you know. And if you ever ask them, what was the core measure value in September of 2014, they could never give it to you. So what we did was we decided we're never going to automate it, right? So the best thing to do is to actually collect it in the data warehouse. It's a very simple thing. So what we did was we created a web form. So our IT department created like this web form, gave access to everyone. They go in there and they punch in their monthly numbers. So you can see here's the month ending, here's the value, numerator, denominator, patient days, if it applies. So in this case, I think it's a 30-day admission rate. So whatever the value is, they put it in. And this is sort of the process that we rolled out. So they put in the data, it goes into the quality data mart, and then we publish the Tableau views using that data, and we create the scorecard. And this is one module of the scorecard. So we have about 9 modules of the scorecard, 9 domains. This is the hospital-acquired infection and patient safety module. And you can see not only, and apologize, again, it's a little bit of a snapshot, but this is how our quality committee decided they wanted to look at it. They wanted to look at it in one snapshot, one piece of paper that gives them all the information for that domain. So here's your, hacks or hospital-acquired conditions. Some of them are really important because they're reported in all these different pay-for-performance or publicly reported programs. So it's very important to track those. So it gives you in one snapshot, it gives you the value, it gives you the prior year value, gives you the target that you want to achieve, the benchmark, and then where are you reporting it. And the little run chart gives you sort of the trend as well. So this really is the collection and reporting burden on our quality coordinators and quality department. And this is another use case of our clinical documentation improvement project. Our clinical documentation improvement and our case management director, Dr. Reed, wanted some better data because he had 3 or 4 different systems to calculate CMI, to calculate his care transitions, and all the stuff that they do. And he came up to us, and we created this clinical documentation scorecard, and he's just loving it. He told me the other day that his son, who's 22 years old, thinks he's so cool to use Tableau. So he's like, finally, I'm connecting with my 22-year-old son. I never did. So I'm like, oh, great, that's good for Tableau, I guess. You connect fathers and sons. So this is another one. I wanted to highlight this. It's nothing great. I mean, it's just, we're trying to identify root cause for reducing our hip fracture length of stay. But what is cool here is when you have good analytics and good data coming through your systems, driving your projects, something comes up, right? Here, do you see this no CM timestamp and no SW timestamp, and how that's the biggest bar? This is something that was identified. So they were looking at reducing hip fracture length of stay in the orthopedic subcommittee. One of the things they identified was the biggest problem in getting the hip fracture patients out of the hospital was their first physical therapy consult, their case management and social work consult, right? Because it's hip fracture, they have the mobility issue, physical therapy. So that had to be mobilized first so that the patient could get out of the hospital and be up and running as soon as possible. So we decided to actually go and grab those timestamps from the system and map it by hours and create those bins and kind of map it by, under 6 hours, 7 to 12. So this is case management, this is social work. And then what we found was a lot of case managers and social workers weren't entering the timestamp when they were doing the consult. So all this work kind of went waste because this data was missing, right? So we went back, created a process where we trained them, told them how it's important and why it's important to enter this. So this is one of those examples where you have good analytics that are humming along. You're also going to clean up your source systems because all those data entry issues sort of come to light. Some really cool efficiency and throughput use cases. So the first one, this is really cool, and bear with me. This is one of the coolest visits that we've done in our organization, I think. So what you see here is the ED daily review report. So we have about 300 ED dashboards running, just so you know. But this is the coolest one. We have the ED daily review. So every morning, it loads at 6 a.m. So you get the data for the last night, all the way through 5 a.m., whatever the data load time is. What it does is it identifies quickly what your variability is in throughput. Because the biggest problems most EDs face are their throughput time. They want to get the patients in and out as quickly as possible. If they have to be admitted, we should admit them quickly and not let them linger in the ED. So what this does is, if you look at each one of these people are actual patients that came through the system that day, right? So these are the hours. So here's your midnight through the 11 p.m. hour. And this is your reception to depart time, which is the overall throughput time. From the time they were received to the time they were discharged, or depart, which means if they're admitted, they go to their inpatient unit out of the ED. So the green people here are outpatient, which means they're treat and release. The blue are inpatient, and orange are observation, right? So immediately just looking at it, you could tell which ones are inpatients. So if you had to identify variability for inpatients versus treat and release, you can quickly do it. You identify anybody outside of this gray band. So this gray band is our one standard deviation, that upper control limit, lower control limit. So this is our sort of band that we want all of our patients to fall in. So immediately, visually, you're drawn to every patient that's falling out of it, right? And you can immediately, on a daily basis, find out which patients were falling out. So now, the cool part is this, look at this guy here. And also, I don't know if you can notice, but you can tell male, female too from the icon. This guy here, right, when you hover over him, the tooltip basically gives you all the details. So you don't have to go back into Meditech and actually find out what happened to this patient. It gives you the patient E number or VV number, visit number, the name, their demographics, who was a nurse, who was a physician, admit provider name, and their total time. So you don't have to worry about it. So you get the data right there, so as soon as you hover. So you can identify the variable outliers and take action on them immediately. This was actually an interesting Lean Six Sigma project. So this came about the other way. So we had a process improvement project to improve our Lean Six Sigma, our lab turnaround time in the ED, because if they felt like the overall ED throughput was being impacted by lab tests not turning around quickly enough. So we created this dashboard as part of that. What you can see here is this is for one particular month, this is by the day. So these are the dates. This is the average order to verify, which basically means the entire term. So from the time the order is put in to the time it's verified in the system. So the average time here, you have stat versus routine, and then you have by the hour, how many orders are, what's your average time and how many orders are coming in. So if there's any issue with too much volume is causing it, you can immediately identify and act on it. So this project was really neat because it was like one of those perfect projects. We reduced the turnaround time in the ED for lab tests by 19 minutes. We decreased the hemolysis because one of the root causes they found was there was increased hemolysis in these lab samples. So they went from butterfly sticks to straight stick needles and actually reduced the hemolysis rate. And as part of doing it, they saved money because butterflies are more expensive, straight stick are not. And also sometimes nurses don't, so we had to do a little bit of training, but a lot of nurses said I would prefer my straight stick because I trained them. This was another one where our CEO of our medical group called me and he said, I don't know what's going on. I just want to find out how much do patients have to wait to get in with my physicians. I don't have average wait times. I don't have how many new patients we're seeing. And there's a huge backlog. And I'm just getting anecdotal, like, hey, just hire more staff. You just need more people to man the phones. You just need, this physician is not productive enough. He's not getting enough patients. So he was kind of tired of it, and he called us. He wanted to track capacity, and he wanted to track scheduling. So we created this scorecard here. It tracks the average wait time. It tracks so this is for a particular group, so I've kind of hit it, but so you could basically filter it for any medical group. So you can look at here, you see the average wait time in days. You see, here's the provider names, so you can look at, obviously I've blacked them out, but by each provider, what their monthly wait time was, and the number of new patients they were seeing that month, or that time. This actually has a huge impact. They're actually looking at creating a centralized call center for some of these practices, and this was one of the practices that they piloted it at. And improving scheduling is part of one of our big Lean Six Sigma projects that my team is undertaking. Imaging service capacity. This was interesting. I just want to show you because I think it's kind of neat to actually drive staffing changes using data. They wanted to understand what the volume is by day of the week in radiology, in radiology, and by hour. So basically what it is day of the week and time of the day, right? So to see what your volume is, obviously on Sunday it's really low, almost across, but you see that little time frame between 8 and 4 is the biggest, obviously. So they wanted to understand, so they created this to make staffing changes. Thought it was cool to track that. This is another one of those about inconsistent and variable data. It looks really busy, but it's a very useful report that we created in Tableau for our radiology director. So when we gave her average radiology turnaround times, she said, something's really wacky. If I look at this data, sometimes my numbers are running in thousands of hours or 5,000 hours. Something is really wrong here. I want my drill down. I want to be able to track each and every patient and see what their turnaround time was by test. So what we did was we created this simple report. Test name is right here. Meditech account number is here, which is basically your V number or whatever it might be, the encounter number. So you could actually go back and look at this exact patient. If it was 1, 2, 3, 4, 5, you can go back and look at the 1, 2, 3, 4, 5 and track why the changes are. And then when the test was ordered, when it was received, and what the turnaround time was. So she could really drill down and identify, hey, why is this 208 minutes? What's going on? Or why is this 235 minutes? What's going on? So this really helps her drill down, and she looks at it daily to see what the outliers are and what improvements or what changes she needs to make operationally. Okay, so now that gets her into operational excellence. So these are scorecards and dashboards we've created to manage excellence and efficiency at the operational level, help our leaders in our departments manage their departments better. This is OR block utilization, so any of you who is remotely connected with OR or surgery or peri-op knows that block utilization is a big issue, and it's really hard, really cumbersome, really complex to manage because blocks change, and it's a huge physician dissatisfier because if physicians don't get the blocks they want, they're unhappy. But if your blocks are unused, you're wasting time and staffing, and ORs are high-ticket cost centers. They're very expensive. So managing the blocks very tightly is very important. And most organizations use third-party software, which usually are wrong because blocks are dynamic, you always need your hands in it, because if a block changes and if something happens, or if a physician leaves, if a group changes its name because now they've been acquired by another group, all these changes are really dynamic and you need to keep a handle on it. So we've created this OR block utilization dashboard whereby, so this is the daily block utilization view. You can understand what your total utilization rate was. So for this, in this case, it's our cardiac and open heart group. You can see they are, so this light lavender color box is their block, and this is their actual utilization. So the block starts at 7. They started surgery at 8 and ended right before 3, which was the 3 o'clock is where their block ends. So you can manage this. So if they, let's say if they went outside of the block, they would go out here. Right, so you understand this way by group. So you have every block is a filter, so you can go block by block and understand whether blocks are being used or not used. And also it gives you your total in-block time and total unused block time. So any group or any physicians that have a huge unused block time, you want to talk to them, understand what the problems are. Do they want their blocks changed? Is there any other issues? So this visual really helps our OR team manage their blocks and manage OR scheduling and timing. And in the process also improves physician satisfaction, by the way. This was one of the scorecards that we did early on for our orthopedic service line. This is the sports medicine dashboard. What she wanted was she wanted one place to get all of our data, that she just wanted one sheet of paper to take to her physicians and kind of say, this is your performance, right? And this is the performance of the service line overall. So this is for our sports medicine. What we do here is we compare annual volumes, we compare quarterly volumes, and you can see the knee and shoulder are separated because those are the two major procedure categories in our sports medicine program. So you can look at knees, shoulders. You can look at data by surgeon for the 3 years. So if there's any surgeon whose volumes are going up or down, like say, for instance, in this case, Surgeon K, something happened, what's the problem? Are you performing surgeries anywhere else? Things like that. So you really have a good visual in one sheet of paper, and then obviously payer mix, because it's orthopedics, it's driven by commercial payers, so you want to understand what your performance are, so you can address the issues right up front. So this is one of those, and this dashboard actually helped us eliminate a piece of software that she was using for reporting and dashboarding, and she was paying around, I think, 75K or 100,000, and we eliminated it by creating this, this dashboard. Now this is a simple bar chart, but this changed Paula, our lab director, her life. What she told me was every morning she would come in and she would actually take the orders, the paper orders, and count them. She had a pile of papers. She would count to get an estimate of how much volume she had the last day, because she did not have daily volumes. She had to wait till the end of the month to actually get sort of sense of actual numbers. So we created this daily lab volume report for her, and she comes in every morning. You know, if she comes in today, she'll see data through yesterday, and she'll know what her volumes are by department. And you can, you can do 30 days, 60 days, however you want, to understand if there's any variability. This is for our medical staff office. They needed one place to monitor and measure physician performance and physician activity in the organization. And this is also used by our CMO and her office to talk to physicians to understand what they're working on, if their length of stays are going up, if their costs are going up. So this is one central place for all of our physician metrics. This particular snapshot is for their efficiency scorecard. We have actually 4 scorecards: financials, efficiency, care coordination, and demographics. So financial is, I'm going to talk to you about efficiency. So what you can see is you have a filter for physicians. So this is for our entire active medical staff. Anybody who's working and admitting and performing surgeries in our hospital is in here. So there's the physician name, fiscal year, month, length of stay, and you can filter this whole information down to a discharge location. So if you wanted to look at one unit versus, you know, your orthopedics unit versus medicine unit, I'm not sure, whichever one, so you could do that, and then you could filter it by payer class as well. So here's your length of stay, here's your CMI, here's your volume and CMI, here's the average length of stay compared to the your adjusted length of stay by CMI, because a lot of physicians say, my length of stay is high because my CMI is high. You must have heard it. So this is to counter that or be prepared with the data for that. And then this is length of stay comparison to benchmark. So this is our efficiency module in that dashboard. There's care coordination for readmission rates. We have cost accounting data loading. So we even have information on their contribution margin per case, what their supply costs are, something similar to what I showed you for the OR surgical variation up front. So we have that dashboard that we are looking at, and most of our medical staff chairs are looking at these to drive physician performance and have a good idea of what physicians are working on. By the way, we did show this to Joint Commission when they came in, our medical staff office, and they were very impressed. They said that this is one of the few things that they don't see this kind of stuff. This is our organization, one of the few ones that they've actually seen something like this. This is Edwin scores. For those of you who have ever worked in the ED or are associated with the ED, this is to understand your ED overcrowding and management of resources within ED. This is our Edwin score dashboard. And the reason it's cool is because it's automated on a 5-minute basis. And we're planning to actually put it up on a monitor in the ED, so our ED staff can look at it on an almost real-time basis. So you have the Edwin score, you have total patients, you have how many patients in each track, and then you have number of doctors on call or on duty, the ED docs, and the number of staffed ED beds. So you understand the entire picture. Before we did this, it was a completely manual process with lots of glitches, multiple Excel spreadsheets. If somebody made an error in one spreadsheet, it would just flow through and everything was wrong. And now we've automated it, and with some programming, we can automate. We can actually refresh the Tableau dashboard every 5 minutes, so it's automatically refreshed every 5 minutes. So this is really neat. I'm waiting for them to actually put it up on the ED screen in our new ED. Last but not least, money, right? So you always want to look at financial use cases. This was comparison report was part of our value analysis teams. What happened was everybody works on value analysis and negotiates contracts and capitation and all that good stuff, right? You all want to get the lowest price possible, especially for expensive items. But one of the things we noticed was there was this thing that was happening. It was called pricing creep. So, you negotiate whatever you negotiate, and next fiscal year or next calendar year rolls around, and the price just goes up because they change list prices. Vendors do that, right? So they change list prices. The price goes up. You're using a lot of it, or the cost per unit of that particular item is really high, and you don't realize the price has gone up. Nobody monitors it. It just sort of falls below the radar because either it's a really inexpensive item or it's not used as much, so it falls below the radar. What our value analysis team wanted to look at was how do we actually kind of stop this pricing creep and have some kind of control in place so that doesn't happen. What we did was we created this, again, it's a simple report, but it's very valuable because every line item could potentially be dollars for the organization. Now, again, this is used by the organization as sort of a guiding report, right? I'm not saying everything that's in here is actually an improvement. Some of them, they understand, they know why it was being used. They know a new physician is using it for certain clinical reasons, and it's absolutely right. But every month, our value analysis leaders and our materials management and our major cost centers like OR, cath lab, those high-ticket items, those departments that use high-ticket items use this. So what we did was here, in this case, it's an OR report. Here's the item description. I've blocked it out just to maintain vendor confidentiality. Here's our item number, our internal Meditech item number. And you see how in 2014, the cost per unit was $11,010, and they creeped it up to $11,225, which is $200, right? Nobody noticed it. But that's a big ticket item, $11,000 for that one widget, whatever it was. And we used 12 of those in 14 and 14 of those in 15. So you see how the net impact is $25,000. So we caught it using this report. And we went back to the vendor and they said, oh, oops, sorry, they fixed it. So, right? So, but the value of this report is, and I can go, there was a single item that I think saved us like a lot more money. I think it was like close to 100K. So what this report does is every month it gives you monthly, like your variance from last year to this year. And also a sort of side effect of this report is you look at your utilization. If something is expensive and suddenly it's gone from 0 to 12, like what is that? We never used it last year. What's going on here? Why are we using it? And it comes back to the value analysis team and they look at it and really adds up overall. Last year, this time, everybody was talking ICD-10. So our CFO and CIO, who manages our medical records department, HIM department, they called me and they're like, we don't have any control. We did all this work and there were project managers working on ICD-10. I don't know if it's actually affecting us or not, if it's going to become a problem for our billing department because they're not able to code, they're not able to bill. So what we did was we took multiple data sources and we created this ICD-10 impact dashboard, working with our physician practice revenue cycle, our hospital revenue cycle, our medical records, and our IT department. We created this impact dashboard for, in this case, it's the DNFB or DNFib, discharge not final billed. So we started tracking them by the month to see if, by the week to see if there was actually changes and if they were not able to bill because the coding was lagging behind. So we ran this dashboard and it was one of those examples that we needed to do it quickly and we needed to do it fast because the data started coming in after October and basically we stopped using this dashboard sometime like the past quarter because it's now everybody knows what happened, nothing happened. So ICU redesign. This was a project, and the reason I'm showing you, even though some of the measures are not that, it's just standard stuff that I've already shown. ICU is a really tough area to isolate cost and efficiency. The reason being the patient comes into the ED, worsens, goes to the OR, then goes to the ICU, then comes back, let's say it gets better, comes back to the floor, but gets worse, goes back to the ICU. So if somebody asks you what's your ICU variable cost, it's really hard to nail down because you can't take that one encounter and say the total, even though the discharge location is ICU, or let's say the discharge location is the floor, but the patient stayed in the ICU for, let's say, 7 days out of the 8 days he was here or she was here. How do you isolate the cost? So we used Tableau. So what we did was we isolated charge data. So we grabbed the timestamp of when the first ICU charge hit to the time that the last ICU charge hit. So we literally took timestamps within the ICU cost center and isolated that date range and took the date range and then went into our cost accounting system and grabbed the ICU costs and the ICU charges. So if the lab was done in the ICU, if the medication was given in the ICU, then we isolated that and then bumped it up against the overall cost. So that's why we were able to do something like this, right? So this is our total hospital average length of stay. This is the length of stay in the ICU. And this is the total length of stay for ICU patients. So just so you understand. So those patients that went to the ICU actually ended up staying here longer, which is intuitively right. And the good thing about this is, I just want to make a point. The good thing about this is that we could do it in about 48 to 72 hours. If this happened, if this question or this business need came up 5 years ago, I don't think we would have been able to do it because we just didn't have the analytical capacity. And we were, at this point, we were analytically mature enough to be able to do this, to bring our cost accounting and bump it into only ICU and look at ICU costs and ICU efficiency. The next level, because we had, as I told you guys, right, like we took the charge level detail and we had exact charges for lab, for radiology, et cetera, et cetera. So we were able to drill down our variable cost categories in the ICU. So you could see how much of, and these are like pharmacy, respiratory, like all the pulmonary tests, et cetera, et cetera. So we could identify variable costs per category. And the reason the room and board is highest is because that's the actual charge to get into the ICU. That's the daily room and board charge. Because we had easy joins with our data sets, we were able to drill it down to this level of detail. And by the way, after we did this, our CMO said, "Can you isolate the trauma patients from this?" I'm like, oh. So we went back and then we went back and actually isolated trauma patients from this and using DRGs and ICD-9 codes. So that just gives you sort of a feel for the level of detail that's built into our systems and our analytical sophistication here. Last but not least, everybody wants to track expenses to budget, right? So this is just a simple, well, not so simple because a lot of programming went in to do this, but we have our general ledger flowing into Tableau, and we do by cost center for all of our department heads. We have an expense variation report. They can track it at the expense category level, so they can look at their expenses, purchase services, repairs, salaries, supplies, et cetera, and then they can look at it from all there. So this is for our executive director of radiology, who has multiple cost centers, and she can look at the variation and also has the level to, or the ability to drill down deeper at the invoice level. So she can track literally if expenses are going up or if they're over budget, she can go back down and drill it down to the invoice level detail using our accounts payable system. So how do we, to wrap up, you've seen so many use cases, so you obviously know that we've really, realized the value. But one of the things that we, and you can read through this kind of stuff, but what happens is there's a cultural shift that happens when there's data available. People are encouraged to do more because they know they have data to support some of their work. They have data to show what they're trying to prove. There's better data to do our research. There's better data to improve patient care. So there's a cultural shift that happens once data is available, because when data is not there and I'm trying to do something new, I'm so scared. I'm like, I'm not going to put in that ticket. I'm scared. I'm not even going there. I'm good. I'll just work on my daily stuff. with something like this, it really unleashes the power of an organization's capability to improve and to make better decisions. And that's exactly what's happened. One of the things that's also happened as a result of all of the work we've done is we've increased compliance and reduced harm events because we have a harm dashboard that runs. We have a compliance dashboard that runs, which I couldn't show because of compliance issues. And then our process improvement group, our Lean Six Sigma initiatives are better because now they have better data to drive improvements, and data is driving improvements as opposed to the other way around where you're trying to improve something because of anecdotal information and then you're trying to get data or scramble to get data to get it done. And we've saved a bunch of money in our value analysis teams. I showed you some examples, and we've saved money overall in our physician productivity, in our physician billing, et cetera, et cetera. So with that, that's a wrap. Thank you. Thanks a lot.
I'll admit, I've never had so much of wisdom and best practices delivered via one presentation. So